Hi, my name is Jonathan Kaufman, and I'm here at Myeloma 2017 in Edinburgh, Scotland, discussing a treatment consensus panel with Faith Davies from University of Arkansas and Pete Voorhees from the Levine Cancer Institute in North Carolina. Great discussion today. Faith, you discussed what we have consensus on, and Pete, you discussed where we didn't have consensus. Can you give us an overview of what you discussed, what we have consensus on, Faith?
Yeah, so I split my discussion into three areas. Areas I thought we had true consensus on, then ones where probably consensus, and then a little bit kind of more woolly, I guess. So I think we all agree that transplant and maintenance are important, that combination chemotherapy is important, ideally with 3 drugs rather than 2, and that we need to personalise therapy, so one treatment doesn't fit every patient. We need to look at the individual patient. So I think those are ones that everybody was comfortable with. There's then ones which most people agree with, and that would be that we can cure some patients. We probably can't, at the moment, don't know which ones we can cure, but there's certainly some patients we can cure. Patients with high-risk disease, we are all maybe a little bit at a loss. Again, we're not quite sure how to define high risk, but there's some work that needs to be done there. And I think the other thing we all agreed on was that MRD is important prognostically and could be used as a clinical trial endpoint.
Yeah, I think that one's a really interesting one because some people put that in the consensus category and other people are using it in their daily practice. And it seems like using a daily practice might be a little bit ahead of the actual data we have.
Yeah, no, that's why I had it in that kind of pseudo one, because I think we can use lots of MRD for lots of different areas. And I think that there's a lot of data there now saying it's prognostically important and it could be an endpoint. But I agree, at the moment we don't have so much any data about using it to direct treatment decisions, although there's lots of clinical trials going on with that one. And then I had these kind of pseudo kind of consensus ones, which were some people in the room agreed with, which I think would be like picking out certain subgroups of patients. We're all really excited about venetoclax and its potential role in 11-14 patients. So I think that's kind of good. We had a great discussion yesterday, actually, about high-risk patients and how we could maybe pull those out and treat those differently. So I think there was much agreement about that. And then I think there's also agreement about us being forward-thinking about how we're going to develop new drugs in myeloma and how we're going to try and change the traditional ways of doing that are probably gone, and we need to think about new ways.
Absolutely.
I don't think anybody knows what they are yet, but we need to think about what new ways.
Absolutely. And Pete, you identified the areas of current controversy in myeloma. Can you review those?
Sure. So I completely agree with Faith with regards to where we all agree, but there are certainly areas in the treatment paradigm which still remain very gray. I talked a bit about the whole smoldering multiple myeloma controversy. There's a lot of us that are interested in treating smoldering multiple myeloma. There are others that are not. For those of us that are interested in treating smoldering multiple myeloma, we certainly want to identify the patients at higher risk of progression to active disease, but how do we treat those patients? Do we use less toxic therapies, monoclonal antibodies, et cetera, immunotherapies, or do we use a multi-pronged approach like the IMF is getting ready to do with the ASCENT trial, basically trying to eradicate smoldering multiple myeloma? I think we really don't know the answers there yet. One of the other points that I had made is that the definition of high-risk smoldering multiple myeloma is a bit all over the map, and I think we need to have a better way of defining, those patients that are clearly at risk of progressing in the near future, because those are the patients that should be going on to the studies. We talked a little bit about, what we do for those patients. I think we all agree that 3-drug induction therapy is the right way to go. But for those patients who have suboptimal responses to therapy, what do we do? Do we continue the same induction therapy for a little longer? Do we switch to non-cross-resistant therapy? Do we just go ahead and transplant them? The MRC did the Myeloma 11 trial, which gets at this issue, switching to a bortezomib-based salvage induction after an IMiD-based induction platform, showing a clear improvement in progression-free survival. But how are those data going to translate into the here and now, where we're using proteasome inhibitor IMiD combinations up front, and we'll eventually be using monoclonal antibodies in that scenario as well? Talked a bit about the issue of transplant. Completely agree, that it remains a very vital part of myeloma treatment, but there still is this debate as to whether it should be done in the upfront setting or whether there are those patients that could potentially save transplant for relapse.
It is interesting that I think all three of us agree that transplant belongs up front for the reasons that both of you outlined. There are regions, at least in the United States, where transplant is very much underutilized, and the folks who sort of advise against transplant use the same exact data that we use to say to do transplant and not to do transplant.
I think that the important thing that we have to recognize is that while there is an overall survival signal that's the same in both arms of the IFM-DFCI trial, it's only 4 years of follow-up at this point. This is 4-year overall survival, and oftentimes these survival advantages aren't gained until much longer follow-up. So that's the first thing. The second thing is that the patients that were assigned to delayed transplant, close to 80% of them got transplanted in the relapse setting. In clinical practice, that does not happen.
Right.
For those patients that defer, we're not anywhere close to 80%.
Right, it's much closer to, and at least in our work, it's much closer to 60%, and that even might be optimistic.
Right, I would agree. So if it's going to work, it's got to be a scenario where patients really are actually getting transplanted as part of second-line therapy. But it's a great opportunity for risk-adapted therapy. Right. So for those patients that achieve MRD negativity, using an assay, either NGF or NGS, to the 10 to the minus 6 sensitivity, can you get away with a non-transplant-based platform for those patients? Right.
And I think at the end we had a very provocative question. Of course, it came from one of our brilliant scientists asking the question, there's so much excitement about CAR T-cell therapy in the relapse refractory setting. Is it possible that we can move it up into what is newly coined the double hit myelomas?
So I think that if we want to truly do something about those patients with definite high-risk disease, we do need to think out of the box. We kind of know what's going to happen if we continue doing the treatment we're doing. We know that their median survival can be 2 years. And so we do need to think about using these novel therapies. And it may be that CAR T cells may be good in that situation because the immune system may actually be healthier in that situation. But I think in order to be able to do that and to do novel studies and novel combinations, including antibodies and so on, we need to define that group well. And we need to do it all in the context of a clinical trial. We can't just be running off and doing it kind of here, there, and everywhere.
Great.
Yeah, I think as we get longer follow-up with the current CAR T-cell trials, if these incredible responses that we're seeing are durable, there's no question that patients with ultra-high-risk disease, should, be afforded the opportunity to utilize those as part of frontline therapy.
Great. Thank you very much.